With that, I will turn it over to Dr. Laura Ferris, who recently joined UNC as the chair of dermatology here, and I will let her take it away from here.
So thank you. It is such an honor to be here, and it's wonderful to have sort of my two worlds collide of the MRF and now UNC. So thank you. I'm looking forward to speaking to all of you and really excited to be part of this team.
Sorry, let me see if we can figure this out.
I'll do much better with my own slides, definitely.
All right, where did my little mouse go?
There we go.
There we go, and from the beginning.
Great, perfect, yes. Great. Okay, so I thought I would talk about melanoma kind of from the perspective of what your dermatologist wants you to know. A lot of times, we're always part of your care team, but we're oftentimes the first people who make your diagnosis and who have to present to you this, unfortunate news and also your plan moving forward. So these are things that have often come up as patient questions. So, how do we diagnose melanoma? One big thing that comes up is what do all these things on my pathology report mean? What are my next steps? What does the future hold? And then how can I protect myself from melanoma in the future and also my family from melanoma and skin cancer in general? So most of you have probably learned about the A, B, C, Ds of melanoma. So these are the kind of things that, these were developed to be an easy to remember, easy to educate on set of criteria for identifying melanoma. So A, asymmetric, B, borders that are irregular, C, colors, meaning multiple colors, and then D, diameter of 6 millimeters or more, or I say bigger than a pencil eraser. And then we really talk about E, which is evolving or changing, which is incredibly important. I put on two other things. One is regression, which is an area that used to be black or dark brown and becomes whiter than the surrounding skin. And then one that I actually think is super important is the ugly duckling sign. So, most of us remember hearing this, but it's really that one, reading this book as a child, but it's that one mole or spot that just doesn't look like anything else on your skin. These are all good warning signs. And, I always say making a melanoma diagnosis, sometimes it can be easy. I think everybody in this room would look at these and say, that doesn't look good. But, these are also melanomas that were much more subtle. So, it's really important that we really keep studying and learning about how to make a correct diagnosis early. And then I like to put up this slide. These are all melanomas on this slide. They all look different. Some of them follow the ABCDs. Some of them do not. Some of them are in areas like nails that we might not think about as being typical areas to develop melanoma. We've got one that's amelanotic or pink, so it doesn't have the black-brown color. So, the ugly duckling, these are really things that didn't look like anything else on the skin. That's an important sign. Okay, so how do we make a melanoma diagnosis? Well, we do a skin biopsy. So, there's a few basics that are important to know. So number one is, if possible, remove the entire lesion. And when we talk about the pathology report, I'll go over why that matters. So there are different ways that your doctor can do this. So, one is, and one of the most common things that we will do is called a saucerization or a shave biopsy. So in medicine, when we talk about a biopsy, sometimes we just mean taking a little piece of something to say what kind of cancer is that, or to get more information. When we talk about a biopsy of the skin to diagnose melanoma, what we really mean is trying to remove the entire lesion if possible, so we can get all the information we need to appropriately diagnose, stage, and come up with the next plan. Other ways that we will sometimes do this is an excision, so an elliptical excision where we cut out with a little, a couple millimeters of normal looking skin on either side and sew it up. And then another way is sometimes your doctor may use what's called a punch tool to do a punch excision. Again, it looks like a little mini cookie cutter, and what we're trying to do is get the whole thing off. So we want to get the whole thing off in terms of laterally, looking at the edges, but also deep to see how deep into the skin it goes. Okay, and why do we need that whole thing? Because when we get a melanoma diagnosis, I'm not just saying, is this melanoma, yes or no? I'm trying to get a lot of important information, and this all ends up in the pathology report, which now with access to your own records, you're oftentimes going to see, and even sometimes you're going to see it before your dermatologist does see it if it's released on. So I like to kind of go over what's in here, because it also helps set the stage for some things you'll hear about later. So one of the first things that we'll look for is what subtype of melanoma is this? And I'm really mostly talking about cutaneous or skin melanoma. So the most common one is superficial spreading melanoma, and that is going to have the best prognosis. But sometimes patients have read that and said, I saw that I have spreading melanoma. Well, it's not the same as spreading throughout the body, so I think that's important. And then there are other types that can be more aggressive, like nodular melanoma or acral melanoma that's on the palms or the soles. The next thing that we're going to look for is the Breslow thickness, and this is how deeply into the skin can we detect tumor cells, and so thinner is better. In fact, in situ melanoma is what we call a depth of 0. So it has not invaded into the dermis. It's just sitting at the top layer. That has the best prognosis. We talk about patients having thin, intermediate, or thick melanomas. We're generally talking about this Breslow thickness. So less than 1 millimeter, we refer to as thin melanoma. 1 to 4 millimeters, we'll talk about that being intermediate thickness, and then greater than 4 millimeters being thicker melanoma. And then the other thing that you will see is Clark level. This is actually not part of our updated staging, but it is on most pathology reports. If I can give you one take-home message, this is not disease stage. So this talks about which layer of the skin, independent of that millimeter depth, which layer of the skin is the deepest in which we can see tumor cells. So you will see a Clark level 4 melanoma, and sometimes patients will see that and they will say, oh my gosh, I have stage 4 disease. You do not. That is just simply another way of looking at thickness. And then ulceration. So what that means is there any breakdown of the top layer of skin? That can be a sign of more rapid tumor growth, and that can be a sign of a worse prognosis or a more serious melanoma. So why are these important to us? So this is a graph that is looking at melanoma, the probability of still being alive despite having melanoma going out to 10 years. So you can see here that the red line is sort of the least steep, that's the best prognosis, and that is our T1A tumors. So when we look at tumor staging, it's really based on the thickness of the tumor, and what we can see if you match up all these numbers is that the thinner the tumor, the better the survival. So really that's one of the first things that we go to when we look at your pathology report, to really know what is the prognosis and what is the next step going to look like. Other things that you will see are mitotic rate. So if you go back to like high school science and you think about mitoses or cell division, that's what we're measuring. We're counting how many cells can we see within that biopsy specimen or within a certain area of the tumor that we can see evidence of cell division. And so the more mitoses that we see, the more active that tumor is, and that can be associated with a worse prognosis. You'll see sometimes mention of satellite metastases. This means basically microscopic small nests of tumor cells that have broken off, and we're really saying, can we see them or not? Sometimes we'll see reports of tumor infiltrating lymphocytes. Not always. So these are basically your white blood cells, the immune cells, and we're trying to see, can we see them attacking the tumor? And you may see absent, non-brisk, or brisk. A brisk TILs, or tumor infiltrating lymphocytes, can be a good sign that your immune system is kind of already on this tumor and fighting it. And then regression, which is what I talked about in that ABCD section. This is, can we see areas where we see scarring, where there used to be melanoma cells and now there's not? And that's, again, generally a sign that the immune system is fighting off the tumor. It can also mean that what we're seeing when we measure where we see tumor cells might not be totally reflective of the original thickness. So why do these matter? Mitotic rate and satellite lesions, you can see again here, 0 mitoses is that red line. That's the best melanoma-specific survival. When you get to 11 or more, the brown line, you can see that the prognosis becomes worse. So this factors into our counseling and decision-making. And then satellite lesions, red is if you have none, and then the other colors are sort of different variations on satellite lesions. But you can see patients who have none do better than those who do have them. Okay. Lymphovascular invasion. So this is saying, can we see tumors that are invading into blood cells or lymphatics? And we report this as present or absent. If it's absent, that's a better sign that the tumor is not sort of going into the way that tumors can spread through the body are either through blood vessels or through lymphatics. And so we'd rather not see the tumor already invading those channels. Perineural invasion is, can we see tumor invading some of the nerves in the skin, which can also be a worse prognostic sign. And then sometimes we'll see, did the melanoma, was it occurring in a pre-existing lesion? So did this develop in what was a normal mole, or did it develop sort of in otherwise the absence of a mole? And then growth phase. So sometimes you'll see this, which is radial, which means its growth phase is going out, versus vertical, which is the tumor is going down. We prefer to catch melanoma in the radial growth phase, not when it's moving, not when it's going deeper, because we know that that tumor thickness is associated with greater thickness, worse prognosis. Okay, just a real quick overview of what is staging. So if we say you have stage 0 melanoma, that's melanoma in situ. Stage 1 is melanoma that is thinner melanoma, basically, with just less than a millimeter of invasion into the dermis. Stage 2 can be melanoma that's either thicker or ulcerated, so a lot thicker and not ulcerated, or a little thicker and ulcerated. Stage 3 is when melanoma has spread to the draining lymph nodes. And then stage 4 is when we see spread beyond the lymph node basin and into either distant lymph nodes, or organs like the lungs, the liver, et cetera. Okay, so what happens next? Generally, one of the first next steps will be surgery of some sort. Not always. We'll talk a little bit about sort of some of the new paradigms of how we treat melanoma. But if a patient has melanoma that is either in situ, so hasn't invaded, or is thinner than a millimeter, and I'm really going to say thinner than 0.8 of a millimeter. Oftentimes that is something that will be done and taken care of in your dermatologist's office. Why is that? That is melanoma where we don't do additional staging through sentinel lymph node biopsy for most of these tumors. So we will, that can generally be treated with surgery alone. Depending on the size and location, your dermatologist may be comfortable doing that in the office. For some, depending on the dermatologist, the location, the size, that may be sent to be done in the operating room with the surgical oncologist. And then, or for what we call Mohs surgery, or really what we're talking about here is a procedure where we can go and actually map the periphery and the depth and make sure that every bit of tumor is removed. This is really only done in certain specialized indications or settings. We don't do this for every melanoma, but if, for example, you have what we call anatomically constrained area, a large but thin melanoma that is, abutting near the eyelid, or near the ears, or on a digit that, we don't want to remove a finger for this melanoma, we may do this procedure to map it out. But for very large for very thick melanomas, we don't do this because in general, patients are going to be going for a sentinel node biopsy. And then this is just a little bit of follow-up. So this is using NCCN guidelines. These are the guidelines. They don't just exist for melanoma. They exist across all tumors that help guide us in the next step. So, what would what part of this is your dermatologist going to want to talk to you about? One is if we look at or melanoma in situ, stage 0, the recommendation from the NCCN is that patients who have melanoma in situ should be getting an annual skin examination, really to make sure that that melanoma, once it's treated, doesn't recur, and because we know your risk of getting another melanoma is higher once you've had one. But there's really no routine blood tests or imaging, so scans. So we're not going to say you need a chest x-ray or you should get a PET scan. If you have stage 1A to 2A that we think has been cured surgically, then in general, we're going to recommend a skin exam every 6 to 12 months for about 5 years, and then once a year, really generally for the rest of your life. At this stage, we don't typically recommend blood tests or scans either. My oncology colleagues will talk a little bit about what kind of imaging and when we would do that. So other questions that come up: should I tell my family to see a dermatologist if I've been diagnosed with melanoma? Having a parent or sibling with a history of melanoma is associated with an increased risk of developing melanoma. Now, that risk is not equal across everybody. So if your great aunt had melanoma, the risk to you is much less than if your mother had melanoma, for example. So we talk about first-degree relatives being parents or sibling. If that family member developed melanoma when they were younger than age 50, that would suggest that there was potentially not just sort of a sun exposure risk factor, but maybe a genetic risk factor. So I really stress this particularly when the family member was under 50. And so I would, talk to your dermatologist about, how much genetic risk or familial risk there is, and who in your family should be getting screened. Only about 2% of melanomas are associated with known familial melanoma syndromes. So these are rare, but there are 2% of our patients out there. These individuals are going to be followed very carefully, usually at least every 6 months. But these are generally people who've had genetic testing, and we know that they possess a gene mutation that does make them more likely to develop melanoma. One thing that also will come up is, should I tell all my friends to go see a dermatologist for a skin check? And so the United States Preventive Services Task Force is the group that reviews all the data for things like cancer screening, so things like mammography for breast cancer, and they have given us a grade of I, meaning that we have insufficient data to say that we should be screening the general public for melanoma. So that does not mean people who've had melanoma. It doesn't mean people with first-degree relatives. It doesn't mean people who've had, other skin cancers, but just the kind of general public, your next-door neighbor who doesn't have a family history of skin cancer. At this point, it's not recommended that everybody go get a skin check. Okay, what is recommended is preventing melanoma. So, people will say, how do you know sunscreen works? And this is one clinical trial that I'll show because I think it's really, it's very simple to understand and it makes a lot of sense. So this was in Australia, where the rates of melanoma are very high. They had 812 patients half of them were given sunscreen and told to apply it every day to their exposed skin. The other half were just said, do whatever you normally do for sun protection. And what we can see here is that the group that got sunscreen is in blue, and the group that was just told do whatever you normally do is in yellow. And we can see that their number of new melanomas is significantly lower in the group that used sunscreen. In fact, sunscreen reduced the risk of melanoma by about 50%, and it reduced the number of invasive melanomas by 73%. So this was really good data that we can prevent melanoma. And then with sunscreen. And then this is just comparing prevention to early detection. And this was modeled, and this looked at, prevention meaning daily sunscreen use, early detection meaning whole body skin exam by physicians annually starting at age 50, and no intervention was just, not doing either one. And this was modeled based on data, partly from the study that I showed, but some other studies in Australia. And so compared with early detection, so people just getting an annual skin exam, the prevention arm of sun protection was associated with 44% fewer melanomas, 39% fewer melanoma deaths, 27% fewer other types of skin cancers like basal and squamous cell carcinomas, and a 22% reduction in skin cancer-related healthcare costs. So really, prevention is, I cannot stress, the best thing that we can be doing. So, in summary, talk to your dermatologist. We are your partners in this journey. We can, ask your dermatologist if you have questions about your pathology report. If you see a new, changing, ugly duckling, please call your dermatologist and let us take a look. If you have a family member who was diagnosed with melanoma before age 50, consider that to be sort of the strongest family history risk factor, and first-degree relatives should be screened. Don't forget about sun protection, and I can't emphasize also the incredible value of the MRF website and programs that they have. The Ask the Expert seminars, you can log on and hear like the world's expert give information directly to patients, answer your questions. So it's really, check them out. They're a great resource. Thank you guys very much.